Hey guys, so here we are starting the very final chunk of material for your final exam. I'm coming to you from beautiful Revelstoke, British Columbia, so I'm sitting outside. I hope it's not too noisy. We left off before your last exam talking about scoliosis and the different types and classifications of scoliosis. So do remember that the final exam is cumulative, so I would definitely recommend going over all of those previous PowerPoints, and then this should help wrap things up. So we'll start off on page 148 with the transition zones of the vertebral column. All right, so every transition zone has a unique name, and it's pretty straightforward because you just combine the two words and put an O in the middle of them. So occipitocervical, pretty straightforward. That's the junction between the occiput and the cervical spine. Cervicothoracic, it's going to be the junction between the cervical and thoracic, so on and so forth. You get the idea. So definitely know how many vertebrae are involved in each of those zones. And remember, it's going to be two. So each transitional zone is going to involve the segment above and the segment below. So the cervicothoracic zone includes C7 and T1. All right, now we'll go into some details regarding each of the individual zones that are useful to know and changes that can happen in each location. So you'll go over this again in dye imaging in 5th try. So I actually just finished it. It was pretty straightforward for me because we learned it in Spinal. So hopefully if you pay attention to this, that will make 5th try even breezier for you. All right, so there's two different types of changes that occur in the occipitocervical zone. So there's cervicalization of the occiput. So your occiput wants to look more like a cervical vertebrae, which is kind of hard to imagine. So it makes sense that it's going to become a little bit bumpy or larger, trying to resemble a vertebrae when it's very much not. And then you also have occipitalization or assimilation of the atlas. This one's a lot easier to visualize. So your atlas, normally a free-floating, well, not free-floating, but you know what I mean, vertebrae is going to actually fuse the occiput because it is trying to become more like the occiput bone. So it's going to fuse to the occiput and then not have its own individual motion. So whether it fuses in part or completely, it's still not going to be able to move freely. So just because if it's fused on the right side, right anterior side, the whole segment is going to be immobilized from moving independently. So don't forget that. All right, so I think this zone is the least intuitive just because it's two segments that aren't directly next to one another. So the occipitoaxial bone is going to be that transition between the occiput and the axis, so C2. And I just think of it like C2 has the dens, so the odontoid process sticks up through C1, and it is going to have some direct articulations with the occiput and a direct relationship there. So be sure to recognize that occipitoaxial is going to be between occiput and the axis, so C2. So we've got a few different types of variations that can occur there. There is the os odontoideum, which is quite a mouthful, so that tends to be a fill-in-the-blank question. Recognizing between this and the next one we'll go over on the next slide. So the os odontoideum is going to be a subdental synchondrosis that persists beyond the age of 7, and it's going to be located lower down on the odontoid process. So those are typically going to be replaced between ages 4 and 7. So you should definitely know that subdental synchondrosis, know that it's going to be lower down on the dens, and note that if it persists beyond the age of 7, it's then called an os odontoideum. So those are a few key points to recognize about that. The other one is a terminal ossicle. So this is it can be easily confused with the os odontoideum, but it's very different. So the terminal ossicle is like a little Hershey's Kiss that's sitting on top of the odontoid process. So it's just at the very, very tip. There's going to be a failure of fusion from a secondary center, and there we're going to have a synchondrosis that persists beyond the age of 12. So again, that age is important to remember. That's going to be located near where the alar ligament attaches, and it's significantly higher up on the odontoid process than the os odontoideum. It's also much less risky of something to see on an x-ray. It's kind of just something you see, it's not a big deal, whereas the os odontoideum, you need to be very careful if you see something like that on an x-ray, because you want to make sure that the integrity of that upper cervical spine is intact and they don't have any instability that you should be worried about. Okay, then we'll move into the occipito-axial zone. Again, sorry, not move into, we're still in it. Now we have basilar impression and basilar invagination. These are also two things that can be confused, and a lot of docs, I imagine, use them interchangeably. In fact, just going through it in dye imaging, it was used interchangeably. However, Mr. Mortar has two distinct ways we're supposed to recognize each of them. Basilar impression is going to be where the chondrocranium is soft, so the weight of the skull is going to push down on the cervical spine, and it's going to form this impression. Whereas the basilar invagination is going to be where C1 and C2 are slipping up inside the foramen magnum. So know that basilar impression is going to be due to the weight of the skull and persistent softness of the skull, so the chondrocranium. And then basilar invagination is technically different, where C1 and C2 can slip up into the foramen magnum. Moving into the cervicothoracic zone. So I shared with you guys that chart, the bumfold chart, recognizing all of the facet orientations for each of the vertebrae. So that's where this comes in handy again, and I will have it at the end of these slides just to remind you what the normal is and then how these change in the transition zones. And that's going to be important for this final exam. So in the CT junction, you could have dorsalization of C7. So dorsalization, your dorsal is your back, that's going to be your thoracic spine. So C7 is trying to look a little bit more like a thoracic segment. So you might have a cervical rib. Know that it's going to be more common in females. It could be associated with thoracic outlet syndrome. And then the change in orientation of the articular facets. Cervicalization of T1 is the opposite, so T1's starting to look a little bit more like a cervical vertebrae. I know that rib 1 could be short and stubby, and then the change in the orientation of the facets. Cervicalization of T1 is going to be more common because having that cervical rib way up high near those very important triangles of the neck, it's going to be a lot less favorable for patients. So those tend to be more rare transitions. The thoracolumbar zone, so the TL junction, again, this is a little bit redundant, but hopefully it makes sense. Dorsalization of L1. L1's trying to look more like a thoracic. You could have lumbar ribs, so that's going to be more common in males. And remember that mantra of women above men. So if you think of it, just a cervical rib is going to be more common in women, so that would be dorsalization of C7. And a lumbar rib is going to be more common in men, so that's a dorsalization of L1. Remember, dorsal is going to be referencing the thoracic spine. Thoracic segments classically have ribs associated with them, so it kind of makes sense that that would be involved in that transition. And then we have lumbarization of T12. So again, the T12 might want to look a little bit more like a lumbar segment, so there may be no rib, or it might be a short stubby rib. And then we have the change in the facet orientation. Lumbosacral, This becomes quite intuitive if you think of it in stepwise form. So when S1 is trying to become more of a lumbar, it's going to try to be an independent segment. So while the sacral segments all fuse, S1 is going to try to remain free, and there will be a lack of a synostosis, so they will not fuse together. The vertebrae itself will become more square and less wedge-shaped, and then the sacral ala flare. Those are all kind of the important points to know. That's where those TVPs are trying to do their own thing. And then again, we could have sacralization of L5, so it makes sense that L5 is fusing to the sacrum. And definitely remember that L5 has the greatest variation of any vertebrae. This is true of osseous features as well as the blood supply and all that good stuff. So know that that's going to be a relatively common finding. All right, between the sacrum and the coccyx. So if the first coccygeal segment is becoming more like a sacral segment, it's going to fuse to the sacrum. And then on the other hand, S5 could be separate from sacrum and may or may not fuse with the coccyx. So either of these two could potentially be associated with birthing problems because you're going to be changing that pelvic outlet. So here is the chart of the orientation of the facets. Again, I would definitely recommend memorizing it. Particularly important for this exam is going to be those changes that are on the right and independent. So that's going to tell you exactly what segment, which parts of each segment are going to be changing, and what the change is. Sorry. Woo! All right, so page 152, starting with the muscles of the back. So I know this is where things start to sound a little crazy again. Every time we hit muscles in the book, it just feels a little overwhelming. But don't freak out. I'm going to point out the most important things for you to know that are heavy hitters for test questions and stuff that's important for life. So this is key. Knowing the muscles with reversed origins. This is one he likes to ask as a fill in the blank all the time. So we came up with this little mnemonic. You know, it's not that catchy, but it does the trick. So LIM, limb, lumborum. So these are all the three muscles that have reverse origins. So L is for longissimus thoracis pars lumborum. And then I is for iliocostalis lumborum pars lumborum. And then M is for multifidus, and only in the lumbar region. So just know the multifidus in the lumbar region, and then everything else has to have the pars lumborum towards the end of it. So limb lumborum. So I would read over the rest of those muscles. I'll point out a few other things as we move along. But then moving into page 157, we talk about the multifidus. If you were in lab, you would know how much he loves the multifidus and its innervation. So if you're studying the innervation for your lab practicals, definitely know the multifidus because it comes up pretty regularly. But it's also pretty straightforward because its innervation is like everything. Know that it goes up to C2. Know, again, that the lumbar region has that reverse origin as part of that limb lumborum. And then in the cervical spine, know that it's not really a prime mover. It's going to be more of a postural controller. There's going to be a lot of proprioceptive fibers, so that's going to be in that capsular ligament. And they're critical for development of the curve, so both in the cervicals and the lumbars, because remember we talked about primary versus secondary curve. So the thoracic curve is a primary curve. You're born with it. You are a little C-shaped individual when you're born, and then as your muscles strengthen and develop, you form those secondary curves. So the cervical and the lumbar curves are going to be helped out by that multifidus muscle. This jumps around a little bit, I apologize for that. So we're back into the erector spinae muscle, so that's page 153, and talking about the iliocostalis thoracis. So know that this is a pretty unique muscle because there's only one attachment at all to the spinal column. So it's going to come from the lower 6 to 7 ribs, and then it's going to attach into the upper 6 ribs and the TVP of C7. So that's the only place on the entire spinal column that the iliocostalis thoracis has a direct attachment to the spine, so that can be a TQ. And its primary function, because it is attached to a whole bunch of ribs, is going to be kind of keeping them together and having them function as a unit. So it's going to attach them all together, provide a little extra stability. And then, so which belly has a reversed origin? Remember again, that's going to be iliocostalis lumborum, pars lumborum, the iliocostalis muscles that has the reversed origin. Moving into the spinalis thoracis, so that's in the bottom of page 155. Important to know here is that it skips T9 for sure, and sometimes he says that it skips both T9 and T10. So I put the page numbers for a reference there, but know that T9 and or T10 are skipped on spinalis thoracis, and so it cannot be implicated in low back pain. That's a question that he likes to ask every now and again. Okay, on the top of page 157, this muscle comes up on fill-in-the-blank questions pretty regularly, so you definitely want to know this in any way that it can be asked. So the biventris cervicis is its own muscle, and it's formed by the fusion of semispinalis capitis and spinalis capitis. So normally those two muscles run parallel to one another, but they are not fused. If they are fused, there is no longer an individual semispinalis and spinalis capitis. Instead, you have the biventris cervicis. So a lot of people get mixed up with these because we've got two capitis muscles that fuse and suddenly become a cervicis. So definitely get that into your brain now, because you just don't want to be doubting yourself in the middle of the exam. But two capitis muscles fused to form a cervicis, and it's that biventris cervicis. Bi means two, so two muscles fused to form the biventris cervicis. We have gone over the suboccipital muscles a couple of times already, and they will keep coming up time and time again throughout your curriculum, so I guess you can never hear these things too many times. So know the 4 muscles, and for some reason I have 1, 2, 3, 1, but it's 1, 2, 3, 4, and know which ones are unique. So I would want to be able to list all of them out. So the RCP major, RCP minor, obliquus capitis superior, and obliquus capitis inferior. And then remember, there's 2 unique things that can happen with these muscles. One of those 4 muscles has no attachment to the skull, and one of those 4 muscles forms no myodural bridges. Then the obliquus muscles are the odd ones out, so they are going to have both of those unique features. So the superior one, if it's superior, it's probably attaching to the head, which means it does attach to the head, so it forms no myodural bridges. Okay, you can rule one of the unique characteristics out. The obliquus capitis inferior, it would kind of make sense that that would be the outlier that does not attach to the skull. Attach to the skull, and it does form a myodural bridge. And then the other unique feature you might want to remember is that suboccipital triangle. So that's going to be made up by those the RCP major, the 2 obliquus muscles, so the superior and inferior. And then remember, the minor is not let into the triangle, or not let into the bar. The RCP minor is not part of that suboccipital triangle. Also know about their function. This is often a multiple choice question. They are not prime movers. That is not what they are designed to do. They're small, fine muscles with tons and tons and tons of proprioceptors in them, so they are postural stabilizers. And always good to know, its innervation, dorsal ramus C1, and it's right in that suboccipital muscle. suboccipital triangle. Again, just trying to hit home those myodural bridges. Remember that they can be implicated in tension headaches. So a lot of those proprioceptive fibers, if you have your suboccipital muscles spasming, that can translate into a cervicogenic headache. So RCP major, RCP minor, obliquus capitis inferior. Those are the 3 suboccipital muscles that form myodural bridges. Okay, your scalenes, you want to be able to differentiate your scalenes, and these things will come back in multiple classes, so this is pretty important. If you're not already super familiar with them, now would be a great time. So you got your anterior, your middle, and your posterior. Know what each of those attach to, first and foremost. So your anterior scalene attaches to the first rib at that scalene tubercle. Your middle scalene also attaches to the first rib between the tubercle and the groove for the subclavian artery, and then the posterior scalene is unique. The posterior one attaches to the second rib. So you definitely want to be able to differentiate that, because that is a classic multiple choice question that trips people up, because they remember about that scalene tubercle on rib 1, and then they forget about the posterior scalene attaching to rib 2 and being different, or the middle scalene also attaching to rib 1. So I just made another point on that question under the posterior scalene. So remember back page 53, which other muscle attaches to rib 2. So remember, we're going to have that tuberosity for the serratus anterior. So that's going to be the serratus anterior also attaches on rib 2. So serratus anterior with the posterior scalene. So you got a little A and P going on there. But definitely know that stuff. All right, then a lab connection. So which scalene muscle does the dorsal scapular nerve penetrate? So this is actually, if you were in lab, this is used as a landmark when you're doing some of the, to orient yourself to be able to notice or recognize which muscle is which. So you always look for the muscle that has a dorsal scapular nerve piercing it. It's pretty obvious, and that's going to be your middle scalene. So once you see that, you know that's the middle scalene, so then you can determine which one's anterior, which one's posterior, and so on and so forth. Okay, proprioceptive transducers. This is a fill-in-the-blank question all day long. He likes to ask the whole list of them. So be able to list all 4 of them, rather. So your interspinalis, your intertransversarii, your multifidus, as we talked about, remember in that cervical region in particular, and then all of those suboccipital muscles. So when you think of proprioceptive transducers, those are going to classically be very small, very fine muscles with a very dense concentration of proprioceptive receptors. And proprioception, so just on the bottom there, just making a point, proprioceptive receptors are going to be within the muscle belly, whereas mechanoreceptors are outside. Okay, another common fill-in-the-blank question, and this is quite a lot, so you're going to have to memorize this whole thing. And we have a couple of fun little mnemonics that probably shouldn't be recorded. So please don't out me. So we've got 7 in total. So we've got our entire erector spinae group. Those are going to be dorsal innervations. That's your iliospinal, your iliocostalis, your longissimus, and your spinalis. Your transversospinalis, so those are your misses, your MRS, multifidus, rotators, and semispinalis. We've got your splenius muscles, your suboccipital muscles, your levator costorum, your interspinalis, and your intertransversarii. So the intertransversarii are the ones that tend to show up as fill-in-the-blank questions because it's a little bit more confusing. So first of all, they're best developed in the cervical region, and then there's only certain parts of the intertransversarii that have dorsal innervations. Because remember, when you think dorsal root ganglia. That's typically like sensory information is coming in from the dorsal region. So there's very few muscles. In fact, this list is pretty much a comprehensive list of the muscles that have dorsal innervations. So it's important to know that. The intertransversarii specifically, so the cervicals is the medial muscle of the posterior belly of the cervical intertransversarii, has a dorsal innervation. So to remember that, we remember peanut butter M&Ms because they're delicious. So PB M&M, posterior belly of the medial muscle, and that's the cervical intertransversarii. And your cervical spine is close to your mouth, which is where those go. Sorry about that, it started raining and I had to run inside and I forgot to pause it. So if there was some strange noises, that's what that was. So we said for the cervical intertransversarii, remember peanut butter M&Ms, posterior belly of the medial muscle. And then for the lumbars, the mnemonic is man bod lacy intimates or man bust lacy intimates, whichever way is burned into your memory. You do you. So it's the medial belly of the lumbar intertransversarii that have dorsal innervations. Moving into the arthrology of the vertebral column. So that's page 166. We're going to go through each of the different types of joint classifications. So we got our fibrous joints, our cartilaginous joints, and our synovial joints. So starting with fibrous joints, just recognize that there's no joint cavity in those. They are filled with an interosseous ligament and they're classified as that amphiarthrosis syndesmosis. I'm pretty sure I've said it about 100 times between exams 1 and 2, so those are going to be our ligamentous joints. Those are amphiarthrosis, syndesmosis, those are the ligaments of the spine. Our cartilaginous joints, we've got a couple different types. So we've got our synchondrosis and our symphysis. So asynchondrosis is temporary. So those are going to be when you are a developing skeleton still, and your symphysis are permanent. So those are made of fibrocartilage. Definitely want to know that. And know that they're going to be most typically located in the median plane of your body. So two classic symphysis joints are going to be your pubis symphysis as well as your intervertebral discs technically. So important things to know about the fibrous joints and those amphiarthrosis syndesmosis. He describes two different types that he will test you on. So which is the best example of a yellow ligament in the spine? Remember that a yellow ligament is going to be very dense in elastic fibers. So we have one classic example that's going to be way above the rest. So that's going to be your leg flab, your ligamentum flavum. And then if that wasn't present on a multiple choice style question, your next best answer would be your ligamentum nuchae. And then I already alluded to this, but so just testing yourself, what are two examples of amphiarthrosis symphysis joints? Remember that's just going to be your intervertebral discs and your pubic symphysis, so those sit midline. Moving into the synovial joints, these are going to be the most important ones for you to know. There's 4 definitive features of a synovial joint, so you'll have to list those out. So I would know those like the back of your hand. So every single synovial joint is going to have a capsule, it's going to have a synovial membrane, it's going to have multiple articular surfaces, and it's going to be lubricated by synovial fluid. So question, what is an example of a synovial joint in the spine? You could choose a whole bunch, but those zygapophyseal joints are going to be synovial joints that go all the way down and form the articulations of your spine. Moving into the types of articular mechanoreceptors. Remember we said those are going to be located more outside. So you're going to want to know all the different types. So there's a couple things for each of the different types of articular mechanoreceptors that you're going to want to know for your exam. So type 1, they're all one word, which is pretty helpful. So they're superficial, Ruffini, they monitor the joints during rest, and they are most numerous in the cervical spine. So superficial, Ruffini, rest, cervical. Type 2, it's all 2 words. So they're going to be made primarily of Pacinian corpuscles. They're going to be in the deeper strata. They monitor your joints during normal ranges of motion, and they're going to be, again, most dense in the cervical region. So a bit of a stretch there. Type 3 articular mechanoreceptors are going to, an example of that is the Golgi tendon organs, the GTO. They're going to be found in collateral or intrinsic ligaments, and they're going to monitor extreme joint movement. And then we got two different types of type 4 articular mechanoreceptors. So remember, four letters, that's going to be our painful monitoring. We've got type A. Type A goes with two A features. We've got the articular capsule fat pad and the adventitia. Type B is going to be found in the accessory ligament and the back of the body of the vertebrae. So again, a little bit of a stretch, but that's going to be your PLL. So B in the back. So continuing on information you need to know about synovial joints, on page 169, Mortar talks about different types of modifications of the synovial membrane. So you want to know all of these modifications. So synovial villi, those are just going to increase surface area. So that's going to be important for diffusing nutrients and byproducts. They also increase with age. So you're going to have a little bit more need for that, a little bit more turnover as you age and things start to break down a little bit. Then you have your articular fat pads. They're also known as Haversian glands, so you want to know that AKA. And those guys are most concentrated and mostly present around those lumbar zygapophyseal joints. All right, then those synovial menisci. So when you think of a meniscus, there's a lot of different places that those are found, but so think of your knee joint, and then you've also got them around C1 and C2 at that lateral atlantoaxial joint. So those are going to just help create a tighter fit, so a better articulation between two joint surfaces. And then your intra-articular discs. So three places you're going to find those are your TMJ, your sternoclavicular joint, and your vertebral column zygapophyseal joints. Then you also want to know about the different types of cells that make up the synovial lamina intima. So the synovial lamina intima is going to be the layer that, intima means intimate, so it's going to be the inner layer of that synovial membrane. So it's a single cell layer thick, and these cells are going to have different functions, so you want to know what they are. So type A, they're going to be phagocytic, and they eliminate waste products. So our terrible mnemonic is APE, A, or some people say A, type IA for 8, because cytosing is eating. So APE, type A, phagocytic, and eliminates waste products, which those kind of go hand in hand. So if you remember type A, 8, then that could work too. And type B, BPH, so type B, it's going to be protein rich, maybe B for buff, and it's going to create hyaluronic acid, so that's going to be part of your lubrication. And then this was a write-in part for the last class, so I don't have this in my book, but he talked about the difference between elastic and viscoelastic properties. You want to know this because it did start showing up as multiple choice questions. Oh, sorry, no, it's the joint lubrication theories that are. Anyways, elastic versus viscoelastic. So elastic is exactly the way that it sounds. It returns to normal rapidly, and it's time independent. So think of letting the air out of a balloon. It just, it's not wasting any time. It just goes back to its original shape pretty quickly. And then you got viscoelastic. So viscous is like a fluid that runs slowly, like molasses is a very viscous fluid. So I always think of memory foam when we talk about different types of tissues and their viscoelastic properties. So there's going to be a slow return to normal, and it's time dependent. So he'll ask questions about time independence versus time dependent. So know which one's which. So it would make sense that something that flows slowly is going to be time dependent. So, or you just think of your memory foam. Those joint lubrication theories, so you guys probably had to write that in, and I don't think he has a new book out, and he doesn't plan on doing one, so you probably had to write this in. So there's 3 different joint lubrication theories. There's weeping, boosted, and boundary. So the 2 that are going to be more heavily tested and kind of matter more are the top 2. So weeping makes sense. Water's driven out of cartilage, so you put any kind of force in, and then it's going to weep out. Just think of crying out of the cartilage to lubricate the joint. And then boosted, water's driven into cartilage. So to differentiate these 2, I just think of like a sponge. So if you have a sponge full of water and you push on it, the water weeps out. And if you have a sponge and you are able to grab each end of it and pull it apart, they're creating kind of a bit of a vacuum. That's going to suck water in. Water's driven into the cartilage. And then boundary is just the 3rd theory. Lubrication's absorbed into cartilage surface. So don't worry about that one. Worry about the water ones. Okay, page 175. So this is going to be the last thing that we cover for this lecture. I'm going to have 3 shorter lectures for this one. The summary of joint classifications, so that's page 175. You definitely want to go over these. I know we've gone over them a couple of times, but again, page 175 and 176, those will come back time and time again. This is part of the cumulative nature of the course and of the curriculum in general. So you got your plane joints. Remember, those are going to be your zygapophyseal joints. That's why it's so important to know the articular facet orientations, because they are flat. So they have to match up with the one above and below them. So your zygapophyseal joints are super important, plane joints. Your intercarpal joints are also plane, and your carpometacarpal. Hinge joints are going to be your interphalangeal and your humero-ulnar, so between your humerus and your ulna. And then saddle joints, joint of Luschka is going to be a modified saddle joint, so definitely know that because that's important. So your cervical spine with your uncinate processes. Remember, uncinate's up, lips lower. And then your carpometacarpal joint, so that's going to be your thumb, and yeah, that one's a saddle joint. Then your condylar is going to be your femur and tibia and your TMJ. Ellipsoidal is your AO, atlanto-occipital, and your ball and socket is going to be all your girdle joints. So anything that you have exceptional range of motion with, your humerus, so your shoulder joint and your hip joint, so your humerus in the scapula and your femur in the inguinal.